Well, ladies and gentlemen, good afternoon. Did you enjoy your lunch? I really wish to invite you to this session moderated by National Cancer Institute of Kenya. I've been introduced. My name is Elias Meli, just in case someone did not get it right. And I'm happy to see all of you seated here. Thank you very much. We are honored to have all of you as our guests this afternoon. We have a serious topic to prosecute and dispense by the end of 2 hours that we are allocated for this session. Feel valued, know that we really appreciate for you to choose to attend this meeting. It means you have a question that you wish answered. There is some gap in information that you wish to know, and we are here to capacitate you this afternoon. We have a team that is going to enable us appreciate, HIV, HPV, and cervical cancer. The topic began in the mid-morning before lunch session, and our able lady from Nyandarua National Polytechnic began this discussion. And I was very happy to know that even when it is not the institute mandated with implementing the cancer agenda in this country, it is a topic that is of great concern to all of us. So thank you very much for finding time to be with us. Now, I know the reason why we are here, as our moderator, Dr. Okoro, has mentioned, there is an epidemiological shift from communicable to non-communicable diseases. Over decades have been a challenge that we have had strategies to mitigate that, which have actually worked. Because hardly does someone die from TB now, hardly does someone die from HIV. I know we mentioned in the morning that we still have around 50 people who die daily from HIV, but we have more that die from cancer in general, and more that die from cervical cancer specifically. So cancer is this disease that begins with a genetic mutation. There has to be some changes in our genes that then enables these cells to multiply uncontrollably, excessively, and has the capacity to spread from one site to another site. And I think what you have contributed into this definition is all correct. So there has to be some changes at the DNA. That is the smallest particle in our bodies. And when this discussion will be continuing this afternoon, you will see how HPV plays a role in causing some changes at our genetic level that then makes these cells around the cervix to multiply. And the wording is excessive and it cannot be controlled. So it is important for us to define what cancer is. And it's the same for all types of cancers. It's also important to mention that cancer is not one disease. It is not like HIV. I know HIV also has a lot of different, uniqueness in itself, but we do not have one bullet for cancer. Cancer is one disease in, more than 200 diseases. Cancer is like, presenting with headache, but there are many causes of headache. In this case, we have cancer of the skin, cancer of the bone, cancer of the blood, cancer of the cervix. Mention every little cell in your body, cancer can begin from them. And the approach, the causation is different. The approach to treatment might be very specifically different, but generally it could be the same. There are two cells in our bodies that cannot be affected by cancer. Which ones are those? Two cells in our bodies that cancer cannot affect completely. There's a hand behind.
Hair and nail. Hair and nail.
Hair and nail. Can we clap for her? You guys are very brilliant and you guys are reading. So it is only the hair and the nails that cannot be affected cancer. But every other cell in your body, potentially, cancer can begin from it. And one unfortunate thing with cancer is its carcinogenesis, the process of causation of cancer. From when you get exposed to a risk factor like HPV that we'll be handling this afternoon, to when it actually manifests itself, these cells should have multiplied 1 billion times for you to see in a microscope that there is a change that is then cancer. Can you imagine 1 billion? That is not little money if you are discussing cash, right? Now, for you to see a speck of it in a microscope, this is a process that is extremely slow, and sometimes it takes up to 5 to 10 years before you present with the symptoms. That is what we call subclinical phase. Now, National Cancer Institute of Kenya is here this afternoon presenting this session. So briefly, just to bring you home, this is a state corporation. It is a parastatal. It is a SAGA, semi-autonomous government agency, just like NSDCC or previously NAC, which is under Ministry of Health. And we were established in 2012 under the Act of Parliament, Cancer Prevention and Control, number 15. We've been in existence for more than 10 years, and we are here to strategically position ourselves to achieve one mandate which this institute was established for: cancer prevention and control. And we want to focus more on prevention, but unfortunately, because of many challenges that exist, we find ourselves doing a lot of work in controlling. And controlling means early diagnosis through screening. We will talk about HPV screening here shortly, all the way to when unfortunately you get diagnosed and you must go through treatment, then you must be able to get quality treatment. And our function number one is advisory to the Cabinet Secretary, health on matters, on priority interventions in cancer prevention and control. We are also charged with a mandate to make sure that there are centers across the country that are able to diagnose and treat cancer. We are also charged with a mandate to make sure there is adequate human resource to address our cancer challenges in the country through building capacity formally and informally. And I would like to mention here, because I know we also have people living with HIV here. We have people who have been doing a lot of work in the community through the community health programs. We are integrating cancer in also through the community health promoters to make sure that informally there is messaging that gets to the people at mashinani. As much as we would want to train top-notch oncologists like myself and others who are here, including Dr. Nisa, who is one of our speakers this afternoon, we want to make sure there is capacity at all levels. That is one of the functions that National Cancer Institute of Kenya has in this country, and we are part of the entire ecosystem of healthcare in the country. We also have another role, which is cancer research. And for us to have answer many questions that we have, the only pathway is conducting research, which can either be clinical research or non-clinical research. It is important to mention here that we have been treating a lot of our patients using foreign data. And unfortunately, just like when HIV began, late 80s, early 90s, a lot of our treatments were based on foreign data. But over time, there has been a lot of clinical research conducted in the country that solved our local challenges. We are following the same pathway with cancer currently to make sure that we originate our own data by our own people that then will respond to the challenge that we have. I will surprise you that we may sometimes be over-treating or under-treating our patients because we are using data generated from people who are biologically different from us. I had mentioned earlier on that cancer is a genetic problem at the beginning, and it becomes a systemic disease when it spreads in the body. And it further causes socioeconomic challenges. because it is one disease that I always equate it to terrorism. And that is why the approach cannot only be through Ministry of Health. We were created so that we become semi-autonomous to be able also to use a multi-sectoral approach, where then we can engage where our risk factors are, which is in the environment. How many of us are farmers here? I am one of them. How many of us are farmers? How many chemicals do we interact with on a daily basis? As much as we'll be talking about HIV this afternoon, remember causation of cancer is factorial. It is not one thing that if you were asked today, what is this one thing that I should do right? You remember this guy in the Bible who met Jesus and told him, I have done everything right. Right? You know that guy? I have, supported, I have even, paid my tithe offering, and he was told one thing, go do what? Go sell what you have. And it was very difficult, right? I think to that point, probably we have an idea. We play a very big role in advocacy, to make sure there is access and affordability, there is availability of quality interventions, whether it is treatment, using, chemotherapy, radiotherapy, or any other systemic treatment, including surgery, which is a very key, modality of treatment. So we also have this huge mandate of creating awareness, public education, and we are regulating that space of cancer to make sure that it's on equality across the entire continuum of care. What I'm doing right now is creating awareness about National Cancer Institute, its mandate and its functions, and we are a body that has, board of trustees and the CEO leading management and staff. We are based at Landmark Building, Landmark Plaza. We are actually in the same building with National Systemic Disease Control Council. And no wonder we are here in this Maisha conference together, because we move as one team. Our approaches to our challenges are pretty much, we have some areas where we converge and we have some areas where we diverge based on the challenges that we have. So specifically, let me bring you to my presentation for this afternoon. I do believe I've created enough awareness about National Cancer Institute. Are we feeling comfortable now that we are dealing with an institute that has, a very special mandate? Can I hear whether that is true or no? Do you agree that National Cancer Institute of Kenya has a special task to deliver to the citizens of this country? So wherever you are, when you leave this place, you be our ambassadors, so that you can direct people to know where they can be assisted. That is why I decided to take these 15 minutes to create that awareness amongst ourselves. So to my presentation for this afternoon, I'm going to scare you a little bit. And my duty, someone mentioned, I think it was Dr. One of the panelists in the mid-morning session, that in health, unfortunately, we scare people and encouraging them so that they can be part of the process. What scares us is when we are also real with you to discuss the burden of cancer in this country. And quickly, what scares us is figures. When you know that a lot of us are being diagnosed with cancer, more often than not, there are people who are quite silent about their health challenges. It is only us who have this mandate to coordinate everything about cancer in this country that then we collect data across board. Patients who are diagnosed and even programs which are involved so that we are able to coordinate everyone. Now in 2020, 10 million deaths occurred due to cancer worldwide. 10 million. That is like a quarter of Kenya wiped out by cancer globally. Now in Kenya, this is the second leading cause of non-communicable deaths. The leading cause is cardiopulmonary diseases. heart and lung problems. But I think with very complete inputting of data, you will be surprised that cancer is underreported big time, and it may actually be the leading cause of non-communicable, deaths. And as we streamline our work, we will certainly give you much reliable data as we move forward. This is the third leading cause of cancer. This is the third leading cause of death in our country. We still have communicable diseases, the infections of this world, which includes malaria, TB, and HIV. And annually, cancer mortality increased by 16% from 2012 to 2018. This then informs you that the burden of cancer is growing on a daily basis. So we are at risk on every day being diagnosed with cancer. And specifically, the latest statistics, this was 2018, every day in our country, every year in our country, we have more than 42,000 people diagnosed every year. And we have 27,000 of those dying. More than 60%, actually almost 70% of those who are diagnosed with cancer on daily basis die by the end of 1 year. If we are in this room and we are 100 of us, every year, 70 of us would not be in this world because of cancer. It's in that a huge burden that requires, intentional support and strategies to reduce this burden in our country. What socioeconomic effects does it have? The impact it has in our country is the high cost of treatment is there. And these people who are diagnosed with cancer, either complications of treatment or the disease itself, would not allow them to contribute to our economy. We lose a lot of hours, man-hours that would be very useful for their families and also for this country, for some of us who are working. And unfortunately, we even end up losing life. That is quite a loss. You would rather be sick and have controlled disease like most patients living with HIV are. They are able to function, they are able to work, they are able to take care of their families. But unfortunately with cancer, we find ourselves losing lives. UHC, to cushion catastrophic out-of-pocket expenditure. We are all awake to the fact that our country is streamlining health delivered in this country through universal health coverage. You saw yesterday, there were bills which Ministry of Health is now proposing to repeal the NHIF Act so that we can have more coverage from NHIF towards UHC. And one of them is primary health care bill or fund. So it's important for us to know that our country is also intentional in this. This should then ideally include holistic cancer care. We have our voice in UHC, and it is important to bring to us that we are actually advocating for those who are diagnosed with cancer within the country. Now, global cervical cancer statistics. If I look at this meeting room, majority of us are ladies. And that is pretty much because of the interest. As much as there are men, we know in our lives, we have our women, we have our spouses, we have our daughters, we have our mothers, our grandmothers, so it's also of interest for all of us to be here. A large majority of global burden occurs in less developed regions, where it accounts for almost 12% of all female cancers, with 604,237 women diagnosed with invasive cervical cancer globally as per data in 2020. Those women are our relatives. Those women are our fellow Kenyans. They are in developed countries. It is us. And high-risk regions with estimated age standardized rates over 30 per 100 include Eastern Africa, where we find ourselves. Southern and Middle Africa, and generally these are in low middle income countries. And cervical cancer remains the most common cancer in women in our region, and over 80% cases in LMIC countries, especially Sub-Saharan Africa, Kenya included. It is a serious matter that it should scare all of us. More importantly, the leadership, because where there is good leadership and governance, then definitely there is going to be service delivery. And the National Cancer Institute has that responsibility. So bring it home. Cancer in Kenya, and cervical cancer specifically. So cancer is the third leading cause of death in cancer, as mentioned earlier on. There is a rising trend, and cervical cancer, what we are discussing today, earlier on I mentioned that it's never one disease, and HPV plays a very big role. I want you to look at paragraph number 4, 99.7 cases linked to HPV infection transmitted through sexual contact. I think this is where we need to discuss. This is where we have actually intersectionality between HPV and HIV in terms of transmission. It is sexually transmitted. We had a whole mid-morning to discuss about prevention using condom programming and programs. And someone mentioned, and I'm happy to see our dear lady from Nyandarua County, she's here with us. Thank you for bringing this topic in that session, and we are at it now. Second most frequent cancer among women aged between 15 and 44. Can I see the ladies who are aged between 15 and 44 years? Can I see them? Can I see them? Tom, don't raise your hands. Okay, so we have majority of us here, more than 90%, we are in that category, and we are at risk of being diagnosed with cervical cancer. I will not ask the second question of how many of us are sexually active, because that is controversial, right? Allow me not to ask that, but I've asked silently. Just know, if you are sexually active, you are at risk. But then, how should we then approach this? Because it's a basic need, as we agreed in the morning session. It is part of life. It's part of growing up. Now, this is the leading cause of deaths in Kenya, aggregated. Whether you are discussing cancer of the brain, cancer of the lung or the liver, cervical cancer causes more deaths in this country than any other disease. And that is why, as much as we are considering all types of cancers, we have to address this one specifically, because it's one disease that actually it's possible to treat with curative intention. It is one disease that we can prevent. And shortly, in my next slide, is elimination of cervical cancer. We've been given a very simple and easy strategy that all of us should know. I am here training us to be advocates. I mentioned earlier on when I was inviting you to this afternoon session that we have a formula WHO has called on every country which is a signatory to WHO, Kenya being one of them, to make sure that we use this approach of 90-70-90, a call to action to eliminate cervical cancer. What does that mean? It means we have to vaccinate 90% of our girls by the time they are 15 years. How many of us have daughters here? Do we have daughters? Yes. Do we also have sons? Yes. Are they also at risk? Yes. We will know how our sons are at risk. But now let's mention about, for elimination of cervical cancer, because our sons do not have a cervix. Someone work on it. I remember one time someone was being asked, you've seen this MTV, random asked in the street, and someone was asked, what is a spine? People have different ways of, defining what a spine is. So I wouldn't be surprised that people may not even know where the cervix is. It is this little structure that connects the uterus to your external genitalia. That is the entrance to the uterus. That is where the cervix is. And we mentioned that HPV, interacts with your cervix through sexual contact because it is the man that transmits HPV. Unlike HIV, that is cross-transmission, but you can contact HIV from either your sexual partner. HPV, if you want women not to be diagnosed with HPV in this world, then eliminate all the men. That can be an easy strategy, right? Should we eliminate all the men? Should we? So what we are being asked is 90% of our daughters at 15 should be vaccinated, with HPV. And I know, I did ask how many of us have daughters. How many of us have had our daughters vaccinated with HPV? How many? The hands were so many that had daughters, but those ones who have had their girls vaccinated are now a drop in the sea. They are older. I've talked of 15. At 15. But let me give you an exit window. We can extend as long as they are not sexually active. If they've not had any sexual debut and they are 17, they are 20, they can still benefit from the vaccination. Just keep your questions, note them. I know Dr. Anissa is here. She will answer most of those questions when her time will be here. Okay? So now, if we vaccinate our girls by 15, and we begin at 9 years, so don't wait until the 14th year for you to rush into vaccination. 9, 10, because we have appreciated that sexual debut amongst our children has come down. Initially we thought children are 18 years, but we've seen girls who are pregnant at 10, 11 years. So then we have brought down, the limit for vaccination to take care of those. We are alive to the fact that there are a lot of changes, there's a lot of cultural changes now in our environment. Now, the second strategy is 70% of all our women, by the time you are 45 years, should have had cervical cancer screening. Whether you are using HPV screening or you are using VIA screening. Again, how many of us ladies who are here have had screening for cervical cancer? Good job. You guys are doing well. And how many people have you shared with to be screened for cervical cancer? Very many. Yes. You are doing very well. You are doing our work. Thank you. I'm going to reward each one of you when you believe in here. All right? Let us continue with the messaging, because it is what will actually allow us to be diagnosed. Unfortunately, if you have already had the disease beginning early, and when you get treated when you are diagnosed early, the outcomes are very good with very limited, toxicities, which then means there's a lot of organ preservation and you can continue with your reproductive life. But when the disease is diagnosed when it's advanced, then you end up, unfortunately, sometimes losing your uterus, losing, your ovaries, and also, your entire reproductive system is affected. And remember, these are people who are before 45 years. These are people who still want to have children. I have unfortunately seen a 20-year-old lose her entire uterus. That means that, lineage is cut. It is quite sad, it's unfortunate, but it has happened. For a disease that we can completely prevent and eliminate out of this world. The third strategy is those who are diagnosed with either precancerous, because this is one disease that does not begin as cancer. It begins as pre. And if you don't address it at that time, then it progresses to cancer, what we call invasive cancer. But before that, it is non-malignant, that you can sometimes treat with just freezing those cells, exposing them to high temperatures, or just doing a slit using some electrocutical mechanism, and you just kill those cells. If you do that, then you remain with all your organs intact, and most importantly, you have your life to take care of what God has planned for you until you exit this planet. So this is the 90, 70, 90. So those who are screened and they are found to have lesions, whether it's cancer or not cancer, 90% of them should be treated. And we are not putting 100% because one thing that we appreciate with cancer is there are patients who have not been exposed to HPV completely, but they still develop cancer. I did mention that 99.7% of cervical cancers are caused by HPV. There is still a 0.3% that are not HPV related. It is important to mention that in statistics, we always conduct our studies with a 95% confidence interval. What does that mean? There is a 5% chance that your conclusion might be wrong. But then you have 95% confidence that what you have concluded is correct. So it's important to mention that. So while you will be leaving this meeting this afternoon, just know that we can eliminate this cancer. It is quite sad and unfortunate, as much as we have many of us here who've been screened for cervical cancer, but in our country, if you saw the KDHS data that was released a month ago, 16% of our women have undergone cervical cancer screening. So it's important for us to know, as much as most of us here have, let us do more to sensitize all, because I know you are leaders from whatever capacities you are in, whether it is through your support groups for the HIV programs, support groups for cancer specifically, we actually are doing badly. Australia is the first country that is likely to meet this target before 2030. But there is hope. We still have 7 years to do this. And if we are going to put our strategies, which are NCI-led, which are community-oriented, trust me, 7 years is a lot of time for us if we have the resources and we have the goodwill and we have a cultural shift for us to appreciate that this is a disease that can be eliminated. So we have HIV as a risk factor of cancer. Because of time, allow me to summarize this way. HIV infection is a major risk factor for cervical cancer. How? This is a key driver of high cervical cancer burden in sub-Saharan Africa. There is a lot to do with our compromised immunity in any cancer procession. And that is why, if you look at the approaches for treating cancer in general in this country, we are now shifting into, modulating our immunity, so that if you are exposed to any risk factor, and that's what vaccination does for our girls, it actually primes our immunity so that when you engage HPV, then your immunity is strong enough and it can fight and overcome cervical cancer and you reduce the risk. So immunity, when it's compromised, and HIV has done that a lot, we have other HIV-related malignancies, not only cervical cancer. We also have lymphomas, which is a cancer that originates from the lymph glands. If I know Mombasa is hot and most of us are not dressed, like how we dress in Nairobi now. If you are in your sleeveless, ladies, or you are in a vest in your room in the evening, if you touch your armpits, these are where the glands are mainly. All of us have glands. They play a very big role in our immunity, but when cancer cells begins from them, then those glands will swell. Just like whenever you have an infection, you will see a gland in your groin area. When you have a wound or an infection in your leg, that is not cancer when you have an infection. Let me not confuse. I wouldn't want you to be worried that when I see any gland anywhere I have cancer. That is not what I'm saying. But I'm just using that as an analogy that sometimes when you have a lot of your glands popping up everywhere, there could be a problem and cancer might be one of them. So then go to the hospital so that you're assisted to confirm whether it's that one or not. This is also HIV related. We also have anal cancers. And anal cancers also has an association with HPV. I know Museveni the other day took a very serious action in Uganda, but we live in a very liberal world that people are choosing what they want to do, what they think is right to them, and sometimes we may not have any control about that. And it is a reality. So for us in health, we also play a big role in advocating for those who are in minority groups, because their health is a priority to us. And if they have a risk factor, we need to prevent. And if they have a disease, we will treat them irrespective of what choices you've made with regard to your social life and status. So that is also another, HIV-related malignancy. We have something called Kaposi sarcoma. This is a skin cancer that you will see someone, and if some of us here have been diagnosed and have gone through cancer treatment, or you've been in clinics, you may have seen fellow patients who have, swollen legs, and you wonder what's going on. Someone had normal legs, but suddenly someone has a leg one-sided more often that is as huge as the leg of an elephant. It is because this is a type of cancer that blocks circulation of fluids in your system, so the legs swell. That is also HIV related. We have many that conducting research might fit this criteria, this category. So when we have increased risk of HIV being, we have HIV driving our compromised immunity. I will show you that if you're HIV positive, you have 6 times risk of being diagnosed with cervical cancer. So if we have some of us who are living with HIV here, and they are being exposed to HPV, you are likely to be diagnosed with cancer, and your risk is 6 times compared to someone who is HIV negative. Are you seeing how it's very important that if we address the HIV problem, we will also address the burden of cervical cancer and HPV infection that is going to be quite a challenge to us. So what integration and innovative approaches do we need to use in this case? So we have to make sure that we have, we invest a lot in information. We need to know what is current, we need to know what is likely to happen in the future. We have to make sure that we conduct screening. We have to make sure that we target, cancer prevention among women living with HIV. And we have to integrate multi-sectoral, women-centered care approach as recommended by WHO. And we must make sure there is community engagement, accessible screening, vaccination, and treatment of what is likely to address the cancer problem. Key focus, we must appraise cervical cancer situation in Kenya. We must measure the impact and progress towards it. We must, whatever you've done, it must be measured. The SMART objectives that we all know. If at all we have any intervention, any approaches, it must be measured for us to know whether we are working or not, or we are investing in vain. We have to reflect on the progress towards 2030 elimination targets. We have to share experience in cervical cancer elimination in the context of HIV, and we have to explore innovative strategies for prevention and control. We have to foster partnerships for collaborative engagement. We have to develop a plan for ending cervical cancer in Kenya by 2030 geared towards global elimination targets. And I know in this building, other than having people who are Kenyans, you are all stakeholders in the work that we are doing at the National Cancer Institute of Kenya. You could be a patient, you could be a teacher, you could be a leader of whatever capacity you are. You could be a partner that has been supporting a lot of activities in HIV space. And here we are creating sensitization that you also have a role that for your You know, there is another session going on in another breakout session discussing about aging in people living with HIV. All right? We have people now living with HIV as old as 60, 70 years. They have controlled their disease. That is no longer their problem. But now they are faced with all these challenges, which cancer is a big one. Generally being, age being a risk factor because of your immunity, which is dwindling, and now HIV makes it even worse. So we have to think together how jointly, collaboratively, cooperatively we are going to, address this problem. So that is my last slide, that NCI's Kenya's journey of ending cervical cancer by 2030 geared towards global elimination target standards as a beacon of hope and progress, leading the way towards a healthier future for this country. Thank you very much for listening to me.